Okay, so hi everyone. Thank you very much for joining us for tonight's webinar, A Specialist Approach to Mobility, the Long-Term Holistic Management of Osteoarthritis. So tonight we are joined from all corners of the world. So a huge thanks firstly to Brian Beale, who is joining us from Utah. Brian is an orthopedic surgeon at Beale Veterinary Specialists in Texas. And next we are joined by Bruno Peirone, who is a professor of orthopedics at the School of Veterinary Medicine in Turin. And then finally, we are joined on home turf by Kinley Smith, an orthopedic surgeon at Willow's Referral Center in Solihull. So from our perspective, this is a really exciting session to be able to collaborate on. Not only to have the opportunity to hear the personal experiences of how you as the expert panel of surgeons treat dogs and cats in real life. And, you know, I'm sure there's some cultural differences between the markets as well, which could be interesting for us to hear about, but also to explore what a holistic approach to osteoarthritis really means and how to best achieve an optimal outcome for pets and their owners. So whilst there is a lot of published data out there across the spectrum in the field of joint and mobility, there are still a lot of unanswered questions that come into play on a case-by-case basis in clinic. So we really hope that tonight will give some insights and practical takeaways that will help to shape your perspective for approaching OA cases in the future. So I think without further ado, I will leave it over to you, Brian, to lead on the main body of the discussion. So have a great evening, everyone.
Well, thank you so much, Millie, and it's an honor to be with this illustrious panel here, and hopefully we'll be able to share a lot of ideas. That's really what the idea of this is to share information so we can all learn from each other. I'm going to go over a quick review of OA, and then we'll answer a series of questions with the panel, and everybody will get their chance to kind of tell what they do in their clinic. And finally, we'll finish up with a question and answer period with all of our participants as well. So I'm going to go ahead and share my screen and go ahead and start first with a presentation here, hopefully. Let's see. Okay, let's see if this works. Hopefully that's working. Everybody, can you see that, my slides there? Okay, great. All right, so we're going to talk about osteoarthritis, and I'm very passionate about it because it's a big part of my practice. Before we get started, I'd certainly like to thank Millie and Vets Pets for hosting this and organizing this and bring this together. I certainly use this product very, very frequently in my clinical management of OA in dogs and cats. I'm going to try to go through this very quickly. I don't know if you can see, but the top of my screen, I wonder if I can get rid of these pictures here. There we go. Move it over to the side a little bit. So, you know, we know that dogs differ in when you treat them. For instance, these all dogs have had a TPLO 1 year before. And when we watch these dogs on their 1 year recheck, let's see if we can get this to advance. Oh, the video doesn't seem to be working. Oh, there it goes. We can see that these dogs all are walking very well after being treated for the same exact condition, a cruciate tear with a TPLO 1 year later. If we compare it to these three dogs, same diagnosis, same treatment, but these dogs at 1 year, you can see are having much greater difficulty with their mobility. So the big difference between these three dogs in each set of cases was the first three dogs had mild arthritis when the surgical procedure was performed, and the last three had severe arthritis. So we know that what we want to try to do is, if we're treating these dogs for whatever condition, we want to treat early. So what this means is we need to diagnose arthritis very, very early. And again, what we're going to focus on is, well, how can we make that diagnosis, and why is it difficult to make that diagnosis? So what are we actually trying to treat? Are we trying to treat the result? For instance, in this image here, we see a lot of osteophytes. So is that how we base our treatment? We look for osteophytes and then start treatment? Are we thinking about what's actually happening in the joint and trying to treat the loss of cartilage? Well, of course, at that time, it's probably a little bit too late to have an effective treatment. And also the muscle atrophy. If we have a case like this where we have lost all of our cartilage, we have lots of osteophytes, for sure we're going to have a lot of muscle atrophy. So we can start to do a little physical therapy. So we can treat the result, but what we really want to try to be thinking about is treating the cause. And we know that OA in dogs, it probably at least 95% of the time, this is a secondary disease. It's not primary OA. And what we're trying to do is diagnose early and treat early so we can treat the cause and the underlying conditions. So hopefully we can limit the amount of OA that we see in these patients. So what are the underlying issues? Well, it could be a cruciate tear, could be an angular limb deformity and abnormal problems with the forces on the joint. It could be incongruency of the joint. So there's a lot of different underlying causes that may need surgical intervention to treat. Now, of course, we may or may not get that opportunity. Another key thing that leads to OA is synovitis. And of course, OA means osteoarthritis, the itis meaning inflammation. And we do know that the synovium is certainly inflamed. Cartilage metabolism. We know that the cartilage cells change based on the forces they're feeling and the biological environment they're in. So is there anything that we can do to treat this? And there's probably lots of other factors that we may or may not even know about. So what if we do nothing? So here's a dog with a partial cruciate tear. And you can see that there's a mild effusion. There's absolutely no osteoarthritic changes. This is 3 months later. And you can see within 3 months, there's already substantial changes in the picture that you're seeing. You can see osteophytes along the femoral condyle, on the tibial plateau, and on the distal patella within 3 months. And so how does that change so quickly? And this is that same dog 1 year later. And so this dog, the owner declined treatment, and you can see the natural progression of the OA where it becomes very severe. But I'll tell you, these radiographs underestimate the changes that are going on in the joint. So what is going on in the joint, and why is that so important? Well, don't just think of the radiograph. I want you to think of actually what's going on inside that joint capsule. So imagine walking around the joint and looking at everything. And we're going to look at the hyaline cartilage, the subchondral bone, the synovial membrane. And what we want to focus on are changes that are perhaps reversible versus waiting too late where they become a permanent change or irreversible. So if we look at the joint, we see that it's not just a radiograph, it's a living organ. And we can see the hyaline cartilage is very, very important because this is actually the surface that actually is giving us that pain-free, good mobility. And the hyaline cartilage is made up of living cells called chondrocytes, along with extracellular matrix, which is made by the chondrocytes, and a lot of water. This is oftentimes forgotten about, the subchondral bone. And with OA, the subchondral bone changes. Well, we don't want it to change. Why don't we want it to change? If you look at it, you can see this, the architectural structure of it, it looks like a mattress. It looks very spongy. The reason for that is it absorbs a lot of energy. So the impact that the animal translates to that joint is absorbed by that subchondral bone rather than being focused on the cartilage, so it spares the cartilage. If that subchondral bone becomes sclerotic, the energy goes right to the cartilage, and that speeds the cartilage abrasion. Synovial membrane. We really don't want it to become thickened, okay? So we want a nice, elastic, pliable synovial membrane. And for instance, some people argue, well, you can treat a cruciate conservatively because they're gonna get a lot of fibrosis and that's gonna stabilize the knee. Well, unfortunately, it stabilizes the knee, but it stabilizes the knee in a subluxated position. And it makes the knee very stiff. Stiff joints hurt. We want to keep the synovial membrane nice and thin, very, very elastic, and that's going to be our goal. So if we look at the cartilage itself, we see these living cells. You can see right here, osteophytes, the chondrocytes in here, the living cells, are actually producing all of those blue fibers, which are the collagen fibers, as well as all the glycosaminoglycans and the hyaluronic acid. So it's very important to keep these cells alive. If they die, they can't be replaced. So chondrocytes don't undergo active mitosis to replace themselves if they're lost. If they're lost, there's no cells left to produce these proteoglycans and collagen, so this will lead to cartilage abrasion. Have you ever thought about why, if you read any article on cranial cruciate ligament repair, and it has medium or long-term outcome, why they all have at least some degree of osteoarthritis progression? Well, why is that? We do a great job fixing them. They're doing pretty well clinically, but why do they still get OA? And I think that that's a big point. OA, despite what we do to correct that underlying cause, is probably still gonna proceed. And so is there anything that we can do to prevent it? What's causing it? Well, what's causing it is the silent factor. There's prolonged joint inflammation. Now, this is very low grade and sits in the background. So this chronic low grade inflammation results in this progressive OA by this very complicated cascade of mediators. So our goal is to minimize synovitis long-term, to minimize the progression of osteoarthritis. So how do we know there's long-term synovitis? The dogs are doing well. It's not because they're having clinical signs. The reason we know is we've had an opportunity to look at hundreds and hundreds of dogs down the line by second look arthroscopy. Here's just 50 consecutive second look arthroscopies of the stifle. These dogs are all doing well. We're doing the surgery on the opposite limb. And you can see that there's not one dog out of that 50 that has a normal synovium. So even though you treat it effectively with a surgical treatment, there's a low-grade synovitis that sits there and lurks in the background. And this is probably what causes all those articles to show progression of OA long-term, even though the dog's doing well clinically. Now, eventually it will catch up with them clinically too, but it progresses in a very insidious manner. So this is what we're trying to avoid. You have normal cartilage on the left and you have abnormal cartilage on the right. And again, if you look at the histo on the abnormal cartilage on the right, you can see that we've lost a lot of our living chondrocytes, and we've also lost a lot of our staining of our glycosaminoglycans because there's no chondrocytes to produce those glycosaminoglycans. So again, this is just another example of what the histopath looks like in normal cartilage, articular cartilage. And you can see the white little lacunae with the black dot in it, which are living chondrocytes. And they're producing all the glycosaminoglycans, which stain in dark blue. Now with persistent synovitis, you get a decreased production of these proteoglycans and increased destruction. So you can see a change in that articular cartilage where we've lost staining. And that's because it's out of balance. It's being destroyed faster than it's being produced by the chondrocytes. But you'll notice the surface of the joint is still intact. So this is potentially a reversible situation. If we can get rid of the persistent synovitis, we may be able to return the balance back so we don't lose the cartilage. So what we want to do is decrease the synovitis so that the cells can get back in balance and produce the glycosaminoglycans to restore the cartilage health. So that's a quick overview. I know I went through it very, very rapidly, but I wanted to leave plenty of time for our questions. And so what we're going to do is just pose a few questions to the panelists, and we're going to give you some opinions of our own. And of course, we base our opinions on our clinical use in the clinics, as well as what we read in the literature. So each of us will certainly give our opinions, and if you have questions as we go along, just type them into the question section and we'll get to your questions at the end of this session. So the first question is, how common is OA pain in dogs and cats? And so, Kinley, do you want to get us started off and answer that question?
Yes. My feeling in terms of osteoarthritis pain manifesting, it's usually at a threshold that the owner perceives that there's a clinical problem. So for that, I would suggest probably 1 in 5 is a reasonable estimate for the whole canine population. But I would qualify that a little bit in that if I take a dog, perhaps coming in for a different reason, a trauma case, and I look at it more carefully, I will very often identify a pain associated with the joint or associated musculotendinous structures that the client's not been aware of. So my feeling is that grossly, I suspect about 1 in 5, but in practical terms, my feeling is if we looked systematically at all the dogs in the population, you could be moving up 40, perhaps even 50% of dogs would have some identifiable joint pain associated with osteoarthritis.
Okay. Bruno, what is in your experience, what do you see? And how about cats? Do you have any opinion on cats? I think you're muted, Bruno. Bruno.
Yeah, I'm fine. Good. Do you hear me? I think that cats are more difficult patient compared to dog for many reasons. It's more difficult to make a clinical assessment, an orthopedic evaluation, and also to see the dog, the cat walking. So it's more challenging, but as an incidental finding, looking at the radiograph, there is a paper that tells that 50% of cats have osteoarthritis at the vertebral column, at the hip and at the knee. So I think it's very common as well. Of course, the cat can mimic and masquerade better than a dog the discomfort. So my point is that we must be able to understand which are the clinical signs of the pain, of the orthopedic pain, and be able to communicate this condition, this hidden sign to the owner in order to manage the patient and to start with a therapy, surgery, or thing like this.
Just a question to everyone. Do you think you see a difference in prevalence between working dog population and pet dog population? Do you think there's a difference between the two?
Are you speaking as far as prevalence or as far as clinical signs?
Prevalence. Do you think the husbandry or the management of working dogs differs to pets and changes the prevalence of the disease?
I mean, that's a very good question. You know, just offhand, you'd say, they're working so much harder, putting so much more load on their joints, so you'd expect them to have more OA. But on the other hand, they're also physically trained and have better muscling too. So, you know, I don't know if I've ever seen a direct comparison in the literature. What is your experience just looking at this clinically?
The only background I've got, John Holton published a study looking at cruciate ligament disease incidence in working dogs or gun dogs in the UK, and there seemed to be, albeit owner reported, a much lower incidence. 6% or something like that compared to about 25% in the pet population. And it's just my feeling is these working dogs are much more athletically trained from a younger age. And my gut feeling, I agree there's no evidence, is that early training seems to offer some protection by mechanisms we can speculate on.
Yeah, I think the same. I don't see many sporting dog, many hunting dog, but I'm thinking to my case log, thinking about the hip dysplasia or cardiac cruciate ligament rupture, the prevalence is in pet and not in athletic dog.
Yeah, I would agree 100%. What do you guys see as far as clinical signs between dogs versus cats? Kinley, what do you see? You know, what's the most common signs you'll see in a dog versus a cat, and particularly focusing on kind of the early stages and what to look for first?
I think we have to be slightly careful in not trying to shovel every single possible cause of osteoarthritis under the same umbrella. As we know, we see different phenotypic presentations. Dogs come in with osteoarthritis with different underlying causes. So, for example, the dog with elbow dysplasia that it's had from a very, very young age will be a different presentation to a dog that perhaps has done a lot of athletic work, or is an obese dog, or has had a trauma. So we have to be careful we don't try and put everything together under the one umbrella. But very often the young dogs coming in and they've had elbow dysplasia almost certainly for a while, and they present at 2 to 3 years of age because the owners noticed a persistent lameness in one limb. We'll have the sporting dogs who might notice an incredibly subtle change in performance, the dog's perhaps not using the apparatus as it ought to do. And then you'll have owners who'll come in with dogs really with multiple joint disease, multiple system disease coming in at an older age. And that's why we will ask the poll question. I'm very curious as to what owners perceive is the problem. Often clients come and say, oh, he or she's not standing as quickly, or a bit reluctant to exercise, or just sits down and a walk. And it's not specific lameness, it seems to be a behavioural change, whereas in younger dogs, it's very often an identifiable lameness.
Okay. Bruno, what are your comments on dogs? And I'm going to go ahead and put up some of your slides. I'm going to go ahead and share the screen.
Yes, thank you. Thank you, Brian. This is something that I see every day. I think like everybody of us see in his practice. And so this is the most frequent question that I receive. Doctor, is my dog in pain? So the owner and the pet and ourselves don't want to have the dog in pain, but you can go ahead. The owner, can you click on, Brian? Yeah. The dog cannot answer, cannot say, yes, I am in pain. So somehow the owner is a filter between us and the dog. So we must be able to communicate to allot some time to speak with the owner. And one of the points is to know well how the dog is walking. Can you play the video? Maybe it's playing. So the dog is a 4-leg and digitigrad, so he's using the digit to walk, and that's 4 limbs. And so in other words, the dog is much able to mimic any kind of some disease, some problem, some joint stiffness. And also the main joint, I mean the elbow, the hock, the stifle, and the hip are flexed. So you can compensate any kind of, most of the problem, just opening the joint. And so can you go, this is something that we must understand very well. And I don't see very frequently situation like this. Can you play the video, Brian? So a dog that is suffering for a bilateral cranio-cruciate ligament and is really with an evident orthopedic pain, right? So he's really unable to stand up, and when he walks down, immediately try to lie down. Typically, can you go ahead with the next slide? Yes. Typically, what we see is this hidden orthopedic pain. So the dog is walking, not badly, even in face of an horrible hip. And so we must be able to understand which are the postural signs. So you see this dog has a typical kyphosis. He tried to sit very, very slowly because, when he goes down in a sitting position, his hip will hurt himself. You see the kyphosis again. And also the comportamentalist explained me how important the behavioral sign. So you see this dog is not happy, is not interacting with the environment. Can you go ahead with the next? So first of all, we must know how is the normal gait. So this is a normal dog. is a four-wheel driver dog, put a full load on each limb and has the head and neck up and is interacting with environment differently. And this is something that is useful also to have it on an iPad and show to the owner. This is normal. And maybe your dog, can we go to the next slide? Is this one. And this is still walking because he's using the limb, but look how the dog is walking, using a shifting of the load on the front as the typical kyphosis, has this woggle tail and the head and neck down. And particularly when you see the dog coming to us, you see how he's able to shift the load on the front limb because he's painful on the back. Very impressive. But still he's using the forelimb, so walking. So, I mean, us as a veterinarian must be able to understand which are the behavioral alteration. Of course, the dog become lazy, sad, aggressive, he's unhappy if somebody's touching his colon or a hip. And also we must be able to understand which are the compensatory posture, the load shift, the head and neck position, and to share this concept with the owner. This is, I think, we have still one slide. And this is quite important as well. So to have time to communicate to the owner, to make the owner understand that the dog is in pain, and to realize together that it's important to have some kind of treatment that can be medical or surgical treatment. This is something that particularly in a busy practice is difficult to have time to speak with the owner. But I think that is one of the key of a success, to be able then to treat the patient.
All right, well, thank you very much, Bruno. So I think, you know, before we move on, I would just say, you know, probably a little tougher to diagnose in cats. You know, there's been some good studies looking at the best questions to ask owners and also what are the most common clinical signs, but certainly probably the most common clinical signs in cats would be they just stop jumping as high or stop jumping as often. They might walk with a stiff gait. A lot of them don't tend to limp until it gets down to the later stages, and they just seem to slow down. They seem to be aging prematurely. But because we know the prevalence of OA in cats is so high, you really need to have a high index of suspicion and maybe just do some survey radiographs to assess that. And then if you have the opportunity, maybe intervene to do whatever you think would be best to try to slow down this progression. So let's go to the next question. Why is OA a problem? Kinley, how would you answer that question?
Every pet is only one half of a relationship. Every pet comes with an owner, and owners have a huge amount of emotion invested in their pet, and they will often anthropomorphize difficulties that their pet has. When people see their dog or cat in what they perceive as discomfort, they obviously want to find out why it's there, what's causing it. And a lot of clients are actually very surprised at a diagnosis of arthritis, particularly at a young age. But there's also a degree of frustration about the effect that it has on the dog's life and how that affects the client's life as well. And there was actually a very, very interesting study published earlier on this month by Zoe Belshaw in BMC Vet Research, which actually went out and asked people who have had a diagnosis of osteoarthritis in their pet how it affected them, how it affected their life. And one of the things that I think I found quite surprising was that pretty much every owner described significant worry and significant concern about coping with their pet with arthritis. The stress of coming to see the vets and the unknowns that are involved there, the feeling that they've let the dog down, that somehow they've caused the arthritis. Did they do something wrong? Did they walk the dog too much? Did they not feed it the right thing? Should they have been giving it some supplements? Getting dogs to take medications was a source of stress for them. And also, they're being told by the vet that they have to keep the dog's weight down, but they're also being told that they've got to exercise the dog less or severely curtail the exercise. So it has quite a profound effect on the client, as well as the very obvious problems that dogs themselves will try to adapt. They will change the way they use that particular joint. That has a knock-on effect on how they use the limb. And that consequently can have effects on their other limbs, front and back. It can have an effect on the spine. It can cause all sorts of secondary changes in the musculoskeletal system, which can then lead into a cycle of loss of confidence, loss of ability, loss of movement. And I think it's often underestimated the effects it has on both dogs and on the client too.
It's a great way to look at it. Let's get into the nuts and bolts of this, and let's talk about treatment now. Bruno, what is your clinical protocol if you have a patient that's, say, got moderate OA, it's a dog? How are you going to treat that dog over the long term?
It's difficult to answer, depends from the joint affected.
Let's say it's a cruciate that was repaired but has moderate OA. His knee's stable now, no meniscal problems. You're just dealing with the OA now, and it's moderate level.
So you're talking about a chronic case, not an acute case.
Yes, yeah.
Yeah. Typically, for me, the cranial cruciate ligament rupture is a surgical patient. So I try to treat the dog anyhow with surgery. The only patient that I do not treat are the ones that are really old, maybe with not painful joint that much, but most of the time I try to treat them surgically. Of course, there are patients or owners that refuse the treatment, and I try to use a multimodal approach if it is possible to reduce the weight, but most of the time it's difficult, particularly in aged dog. I try to stimulate the exercise. I send the dog to the physio, and I start with anti-inflammatory drugs, usually for the first 15 days, and then I go ahead with, or maybe even 3 weeks, because as you show, Brian, to close the circle, or to try to close the circle with the chronic synovitis, I think that the prolonged anti-inflammatory therapy is important. And then I use supplementation with chondrocyte. But in my experience, chondrocyte, they work well in a mild arthrosis, not in a dog that have a severe degenerative joint disease, for the reason that you expressed, because in that patient, there is not cartilage anymore. Most of his dog has a full eburnation of a cartilage and bone-to-bone contact.
Okay, thanks. Kinley, what do you do managing these long-term OA patients?
For me, it's very much breaking the presentation down into the primary and secondary components. And I often find you're looking for a primary disease, which might be the cruciate ligament rupture or disease. It might be elbow dysplasia, whatever that problem is. But then it's very, very accurately detailing how else that dog's mobility is being affected by that condition. So very commonly, for example, in dogs with chronic OA and cruciate, following cruciate ligament disease, I'll find problems associated with the joints either side. So in the hip, they might be reluctant to extend it because it puts pressure on the femorotibial joint. or they might increase the range of flexion in the hip. So these dogs will quite commonly have pectineal myopathy, very commonly have iliopsoas myopathy. So look very, very carefully at that. Try and understand the effects then elsewhere. You'll often find lower back pain as the dog increases the spinal torsion to try and compensate for a lameness or gait asymmetry in the hind limbs. And then you'll very commonly find that you will have increased muscle tension, muscle discomfort associated with the muscles in that limb and elsewhere. So it's trying to find, why did that dog come into me? Why is it presenting to me now? And if it's had chronic disease, it may have been an insidious onset, it may have become progressively more uncomfortable, or it may actually have had the condition for a very, very long time, and something has happened for it to then present acutely or semi-acutely to the vet practice. And we're looking in a bit more detail, as I think you are as well, with MRI, to try and tease apart the information as to why these dogs are coming in. And some dogs are presenting with marked synovitis, which would suggest something like an acute on chronic flare of arthritis. And these dogs might respond well to intra-articular anti-inflammatories, something like methylprednisolone. Whereas other dogs are coming in with periarticular injuries to the ligaments, to the patella tendon, and some dogs are coming in with subchondral bone bruising, which seems to be profound and progressive. So I think you have to be very, very careful how you approach these cases, because it's very easy to go down the multimodal pain pathway and just try and dampen everything. But I think if you've got a better understanding of each of the individual components, you can then formulate a plan, a more detailed physiotherapy plan, a more detailed pharmacological plan, and then any supplements you need on top of that, so that the client has an overview of what the dog or cat has, and has multiple different ways of targeting it. It also allows you to monitor the progression of your treatment a bit more accurately.
Okay, great. Well, thank you. You know, the way I treat dogs that have, you know, chronic OA, and it could be, you know, let's take the mild or moderate case. And I'm going to take that first example, a dog that had a cruciate surgery. And like most cruciate surgery dogs, they get a little bit of OA. So I've already eliminated the underlying condition as best I can. Now what I'm going to do is try to manage this OA long-term. Well, I know from the literature that these dogs are very likely to get OA, even though my surgery was perfect. There's nothing I can do to prevent it. My rationale is I believe that the OA is predominantly due to synovitis. The secondary changes we see due to this OA, such as muscle strains, the back sort of stress and strain, I want to try to avoid those by getting the joint more comfortable. And so what I'm going to do is focus on treating the biology inside the joint. So if I think that synovitis, which we've proven is there at a background state, low grade, basically for the lifetime of the dog in the hip, elbow, and knee, I'm going to focus on trying to reduce that inflammation to the lowest level possible. So what I do is I do start with an NSAID, and I will use that NSAID probably for 3-4 weeks. And sometimes I'll tailor that dose to something where I see the patient comfort, so I'll go to the least effective dose. I'll also match that up with some fatty acid product. And there's a lot of different fatty acid products out there. Of course, these omega-3 fatty acids do have an anti-inflammatory effect. So we're using 2 different anti-inflammatories. One is a drug, one is a supplement. So I'll use these together, and then after 3 or 4 weeks, I'll wean them off the NSAID and leave them on the omega-3 fatty acid supplement. And I'll just add, you know, there's a lot of omega-3 fatty acids out there, but, you know, really, there's not a whole lot of outcome data on a lot of the products that are out there that are published. So I would encourage you to try to look for a product that has outcome data in selecting your fatty acid. So I'll keep them on the fatty acid continuously long-term. Why do I do that? To try to suppress that synovitis as much as possible, to make the biological environment in the joint better so that we hopefully can reduce this progression of OA. Now, there are flare-ups, you know, and so when you do get a flare-up, then I will add on the NSAID, but I'm trying to pulse the NSAID therapy to increase my safety profile. Instead of just giving an NSAID every day for the rest of the dog's life, I'll use it when the clinical signs flare up, and then in between and continuously, I'll use a fatty acid product. Now that's trying to treat the cause. You know, as far as treating the effect or result, again, if we've got muscle issues, we'll go with PT. If we may go with other pain management, you know, we can certainly bring on a variety of different types of pain management products out there, gabapentin, tramadol, other things. I'm not a big fan of expecting a lot of efficacy from that, but certainly they may help, and we can try that out. There's new products that are going to be coming out very, very soon that may help to reduce neurogenic pain, and that will help us as well. And there's lots of other modalities, physical modalities that we'll consider too. So we'll try to do the multimodal thing. But again, for me, the most important thing is suppressing that insidious progression of OA by suppressing the synovitis. Okay, let's go on to the next question. This is probably the last question. How can nutraceuticals impact management of OA? So Bruno, can you give us a quick answer on that? And then we'll follow up with Kinley, and then we'll go to the question and answer period.
As I told you before, Brian, I think that nutraceutical may help. I think that the best spot for nutraceutical are the low degree of osteoarthritis. I mean, not the severe patient, the patient that have a loss of cartilage. And I think that they work quite well in combination with anti-inflammatory drugs. We made a study with a force plate analysis comparing patient affected by, as far as I remember, hip coxarthrosis and stifle osteoarthrosis. So we made a study that was matching the two groups. The first one with just anti-inflammatory drugs, and the second one with anti-inflammatory and nutraceutical. And there was an evidence of better outcome of a patient of the second group with the combination of the two.
Okay. Can you give us your thoughts on this? Kind of a brief answer.
It's very difficult to be specific. I think there are a huge variation in the receptiveness of the disease between patients. And I suspect that the mechanism of action may be as much related to changes in the gut microbiome and how that affects intestinal permeability and its consequent effects on joints. There's certainly lots of very interesting evidence coming from human studies looking at the effects on the microbiome of these products. But because there's such variation, you know, there are dogs who will have a spectrum from very healthy microbiomes to problematic microbiomes, and so you might expect a dog to respond variably, or a different population to respond variably, some showing a very good response, some a partial response, and some no response. And that's certainly the pattern I feel clinically, that some dogs it doesn't help, or we can't see any clinical benefit, whereas some patients or the owners are very, very happy with it. And even, you know, I get the clients to do a sort of semi-blinded test where one partner gives the dog the medication or a placebo, and the other tries to tell when the dog has had the nutraceutical. And in a few cases, there's been a fairly accurate correlation. So I think for some patients, it can be very useful. I think for some patients, other treatment modalities are better.
Okay, great. Millie, do you want to take us to the question and answer session?
Hi, everyone. Thank you. That was brilliant and really insightful. So absolutely, it would be great to sort of just open the Q&A by discussing the poll results. So firstly, thank you very much to everyone who voted. So we'll start by saying that it's really interesting that only 3% of the respondents see pain as the most common trigger for pet owners to bring their pets to the clinic, whilst 88% of the time the trigger is lameness or mobility related. Now, is that a surprise to you?
Actually, that's not a surprise to me at all. If owners are actually bringing their pet in, they're going to see something obvious, and typically that's going to be lameness or dogs just having trouble getting up and getting around. So that doesn't surprise me. What I would challenge veterinarians to do is on your evaluations annually, look for the subtle signs yourself to try to get to this earlier so that you can intervene and try to slow this progression so you don't get to this stage where the clinical signs are quite as severe. What do you guys think, Kinley and Bruno?
Yeah, I mean, I suppose I'm slightly surprised. My experience in my time in first opinion practice was picking up dogs that were often slowing down, not walking as far. And as you say, it's often on the annual checkup for vaccinations or otherwise, where if you explore more deeply, the client brings up the concerns, and then the clinical examination gives you an indication there may be an underlying joint disease that needs investigation.
Of course, the lameness is the number one, but also I remember many owners that are telling me that the dog is not doing the same as before. So just reduced mobility, inability to jump, to play around and things like this.
Yeah, I kind of think of the human situation a lot. Most of us, we start to feel joint pain, go to the doctor and say, my joint hurts. And then they start to treat, and they diagnose OA and start to treat. Well, if we waited till the end stage where we were limping like crazy, then we're probably going to be less treatable. So again, the early diagnosis, I think, is very, very important.
Okay.
Second poll?
So second point that came out of the poll is that this, despite lameness and reduced mobility being the most common triggers, pet owner compliance seems to be the biggest barrier to successful management of OA at 76% of the challenge. So do you think that this could be because of a discordance between what pet owners see as important, which is potentially, within their sort of non-professional view, the mobility that they observe, versus what the veterinary team see as important, which is the actual pain that the pet is suffering?
That's it's such an interesting subject. I think, as Bruno said, that spending time with the client to communicate the information, what's important, is vital in their understanding. So, for example, the weight loss, we all tell our OA patients to lose weight, but I find if you explain to them the background by which building up adipose tissue leads to exacerbation of inflammation, and they understand that the role that fat has in obesity, they're much more inclined to be compliant. But that in itself, that's a 15-minute discussion with the client. So it's the education that they have, but the magnitude of the task, we bombard them with information about medications, about diets, about supplements, about exercise, and they have to take this information in, and it is difficult for a quite stressful environment for them to take that information. And so, there are some good sites out there which provide excellent information. One in the UK is Canine Arthritis Management, which provides lots and lots of information and practical backgrounds that clients can use and follow to help treat the dogs. But I think a lot of it is frustration or lack of understanding or appreciation of what we're trying to communicate. And I think that the problem with that lies with us.
And also is, sometimes you see that the dog is improving, but it takes time. It takes a lot of time, and you have to prove somehow to the owner that he's improving. And this is time consuming both for the vets and both for the owner. Managing correctly a patient with osteoarthritis is quite time-consuming. This is my opinion. You don't see, you know, with a surgery, you see immediately treating a fracture, the dog walk the day after. Treating a chronic osteoarthritis maybe takes 3 months to improve, 2-3 months to improve. And this is not simple to be accepted by the owner. And our work is to make the owner understand that the dog deserves the treatment because it's in pain and it will take time to improve.
I mean, I think the final insight that came out of the poll really reflects what you've said there. So 94% of attendees reported that they are at least somewhat confident in their diagnosis and management of OA. So it really does seem that the pet owner compliance is the big issue that the veterinary teams are up against. So, you know, as you say about the communication and having the time to really, you know, equip the owner, but it seems like, you know, it's very overwhelming, but there are a lot of resources out there. So
move to some questions, some live questions.
Absolutely. So one of the questions that we have is, in terms of supplements, do you find more useful fatty acids or chondroitin, glucosamine, or both?
I'll be happy to answer that. You know, there's kind of, you know, I certainly rely more on the fatty acids, but I certainly use both. As I mentioned before, I use the fatty acids as a way of controlling inflammation. So I'm using it as an anti-inflammatory. And the reason I'm using that long-term as my anti-inflammatory of choice is because of the safety profile. So we know long-term use of the NSAIDs can increase our risks associated with liver, kidney. And so that's why I choose that. That's why I try to pulse the NSAIDs with the fatty acid. If you look at the literature on fatty acids, there's been some good outcome data, force plate data that does show that it does give improvement in mobility, improvement in force plate values, actually very quickly. You can see changes in a week or two, which is quite rapid. You know, as far as the the chondroitin sulfates and those type of products, you know, I think that most of the data with that is a little bit controversial. There's some that seem to show an effect and others that show no effect. There's some suggestion that those products are going to work better early, although there was one study that showed it actually worked better later. So it's just very conflicting, and the studies probably, you know, could be improved as far as their the way that the studies were put together. But to make a long story short, I'll use fatty acids and add on chondroitin, glucosamine, if the owners are willing, and knowing that maybe we don't have the proof, but if they're willing, since they seem to be quite safe, you know, I go with why not.
Okay, great. So there's a couple more questions. If maybe I could fire another one at another panel member. Kinley, I don't know if you're up for taking on this one. So with regards to patients who have gastric upsets to non-steroidals, what would be an alternative approach to reducing inflammation and pain initially prior to managing long-term OA?
Yep, so as I said before, understanding the profile of discomfort in these patients is critical. It's very rarely a single point, and very often there's discomfort in extrarticular and distant sites as well. And personally, if the discomfort is associated with an acute flare-up, and I always look at joint fluid and make sure there's no problems, look at the profile of the cells in there. If there's lots of cells, often synovial sites, so synovial fluid analysis is very, very easy to do. It's something we should do more of. Then I'll often use a local corticosteroid in most dogs. It doesn't seem to cause gastrointestinal upsets, I will often use it if dogs are on long-term non-steroidals. I will often use local steroid therapy without any concerns and without interrupting the non-steroidal as well, without any problems. I don't recall ever having an issue with that. So that's a way to very, very quickly suppress a local intra-articular source of inflammation. But actually, very, very commonly, it's often something else. So the classic one for me and elbows is people will come in, they've got identifiable elbow pain, you manipulate the elbow, they react to that. But actually, what's making them uncomfortable is they've got an acute flexor tendon enthesiopathy, and it's incredibly painful. And treating that either with using extracorporeal shockwave therapy, which I find incredibly effective, or just a local installation of depomedrone or other steroid of your choice, can be incredibly quick. And I've had dogs that have been lame for months, 6 months or more, and 1 or 2 sessions of shockwave therapy or a single steroid injection. And these dogs, not just a little bit better, they are significantly better. So we've got to be very, very careful that we don't try and crack a nut with a sledgehammer of these. Just on pharmacological management, a drug that I'm very, very happy with at the moment is amantadine. Very, very safe profile. It's a human antiviral drug, multimodal effects, and seems to be very, very useful at dealing with a whole host of discomfort from neurogenic, muscular, and articular as well, as a very, very safe profile. But typically, if a dog has an acute gastritic reaction to a non-steroidal, I'm asking questions as to why. Is it a brachycephalic dog? Has it got some other form of inflammation, metabolic syndrome, or something like that?
Okay, brilliant, thank you. So next question, potentially for Bruno, if you're happy to take this one. The recognition of pain in animals, as you say, is relatively poor. Do you think we underestimate analgesic requirements? And if so, is dose titration of non-steroidals a good strategy? Bruno, we can't hear you.
No.
Brian, would you like to take this one?
Okay, let's see.
Would you like me to repeat the question?
I'm just trying to find the question again on here. It's
from Colin.
Okay, that's the recognition of pain in animals is relatively poor. Okay. Yeah, I think, probably what is going on in the joint is not appreciated as soon as it could be. And I think that animals do have discomfort oftentimes. And getting back to what Kinley said, and Bruno also, just think about how the animal was acting a year ago and how he's acting now. And has he slowed down? Is he not doing the tasks that he used to do? Is his posture changed? He may not be displaying anything painful, but the reason he's doing those things is because he is having pain. So I believe that probably animals have more pain than we realize. A lot of this is insidious and hidden and latent. And, we need to try to recognize that and educate the owners. A lot of it is taking time to communicate with the owners, and not only communicate, but educate them. And they're not going to, you're going to have poor compliance unless you educate them and tell them what's going to happen if you don't do this. And unfortunately, if they don't do this, for the long term, things are going to progress insidiously until it's too late. Okay, brilliant. So I think the next one we will go for is from Vivian. So do you recommend other modalities such as acupuncture, laser, physio, and hydrotherapy to improve pain relief and support treatment?
The short answer is yes. We have to be careful that we tailor our treatment therapies to the individual patient. I don't believe there are two identical cases of osteoarthritis. All dogs, all cats will present differently, and all dogs and all cats may respond differently to different therapies. I'm sure I've seen cases where acupuncture has been useful. I've seen cases where I don't think it's been useful. I wouldn't say it's a frontline treatment for me, but certainly the hydrotherapy, the physiotherapy, I find absolutely critical to managing these cases. And when you just think of yourself, think of all these little niggles you've had that have caused you discomfort, little muscle injuries, tendon pulls, niggles and joints, and they change the way you walk. They can give you back pain if you're standing awkwardly or sitting awkwardly or you're not sleeping properly. We don't even try and diagnose these in dogs because it's very, very challenging to do. But actually, when you stop and start to take pictures of dogs, I take pictures of my dogs from the side and from behind, so I can look and show the owner how their posture or conformation might be different to what I would expect it to be. And then we can discuss mechanisms by which we can improve that. I do a very, very detailed, just visual gait assessment, looking at how the dogs are moving the joints. So when I send them for physiotherapy, I can write to the physiotherapist and say, this dog is not really extending its elbow at foot strike like I'd expect it to be, and as a consequence, it's not lifting its back, back left leg to compensate for that in the way I want it to do. So the physio's got a much better idea of what we're trying to do. And hydrotherapy, again, it's not a blanket treatment. You can't just put dogs in a swimming pool or a hydro treadmill and expect them to get better. It's got to be part of your treatment strategy. Do you want to develop muscle bulk? Is it neuromuscular coordination following cruciate ligament disease that you're wanting to treat? So it's really, really important to understand what it is you want to get out of physiotherapy, hydrotherapy, or acupuncture, or laser therapy, and then convey that to the owner, convey that to the person that's doing it, and have a way of monitoring it long term.
Okay, brilliant. So I think we've got time for one more question. There's actually, it's such a brilliant engaged audience. There's been loads coming through. And so I'll just say quickly now before posing the final question that Brian said that he will send the deck to everyone as a follow-up. So, if you have any questions that haven't been answered, I think the panelists would be happy to answer them directly to you as a follow-up. So sorry we haven't got through them all. But final one for this evening is from Harriet. Are there any recommended pain relief if cruciate injury is diagnosed for a dog with kidney failure?
Bruno, are you alive again?
I don't know. Do you hear me?
Oh, yes. Yeah. Go ahead, Bruno.
Actually, honestly, I don't know. Any recommendation pain relief if cruciate injury is diagnosed in a dog with a kidney failure? Honestly, I will ask to a guy of internal medicine or thing like this. I am not the one good for the answer. I apologize.
I'm certainly going to go back to the fatty acids and the more the nutraceutical type line and try to do a multimodal with those, and then go with some of the modalities that Kinley just talked about to try to get local relief depending on which joint is affected. Kinley, what do you think? Yeah,
we have to be careful that we don't blame non-steroidals for all the evils in the world. I recall a study in cats with chronic renal failure, which actually showed that the cats that received a non-steroidal actually had improved life expectancy compared to those which didn't. So in some cases, a non-steroidal may be the best treatment for that patient in terms of giving it quality of life. And with careful monitoring of renal function, it may actually be the best overall picture for the patient to be on a non-steroidal. Conversely, multimodal forms of other drugs, amantadine, gabapentin, as you talked about, Brian, may actually be a more suitable combination for that if there's concerns. But I don't always think that renal failure has to be a reason that the patient mustn't have non-steroidals. But you should always, consult, the medics and anesthetists on this as well.
So, are you personally using NSAIDs in animals that have kidney failure?
It's often not my treatment of choice as a frontline treatment. I don't have a lot of experience with galoprant, meant to be slightly better. I would probably reach for amantadine before anything in combination with physiotherapy. But in some cases, the very, very end stage dog where surgery, salvage surgery is not an option, the client wants to pursue medical management, I may look very, very carefully, do every 3 to 7 day renal function checks and introduce non-steroidals that way to see if we get a clinical improvement without any deterioration of renal function. And as long as you have the conversation with the client and discuss the pros and cons of trying that approach, my experience of doing so has actually been very favorable.
Okay, yeah, I would agree with that, especially in the USA where everybody's so happy. We have to be very careful, and with our board too as well. They would, be very, very skeptical if you were using NSAIDs with an animal with kidney failure. So, anyway, great answers.
Okay, well, that's such a brilliant session, and great to get all of your perspectives, guys. As I said, to everyone who's been in the audience, we will follow up. If you were interested to try Antinol, which is the marine lipid concentrate to support the metabolism of dogs and cats who have osteoarthritis, it will be possible as a vet to access 2 free trials. And if you could click through in the follow-up email afterwards, you'll be able to sign up for them. So I think, as I said, Brian will also be in touch. And thank you so much to all of the panelists for joining from your respective countries, and look forward to being back with you all in person soon.
Thank you, Millie.
Thank you very much.